ahead and open this up because I know we have a packed panel and a full hour.
I will, and thank you, Angela, and thank you to our sponsor of this panel, Orchard, for this terrific opportunity to jump into these really important issues. Let's see, Angie, I don't know who's moderating the panel.
I am. So
I'll turn it back over to you, Angie. That was easy enough.
Absolutely. Hand it on back. You. Absolutely. So yes, again, thank you to our sponsor, and I certainly am honored to be able to moderate this panel. As I shared at the beginning of the conference, obviously, given my experiences and my child's life experiences, it is a personal matter. Certainly, as I was preparing for this panel, I was recalling, in sometimes a post-traumatic way, the challenges of navigating your child's illness, the emotions associated with that, along with the complexities of our healthcare system, the many specialists, the many procedures, all of those things, and how overwhelming that can be. And that's coming from someone that I have my master's in social work. I have worked in the health policy insurance arena my entire career, have a family full of doctors, and I didn't have to even, I can't even imagine trying to then also add on the challenges of managing Medicaid access across state lines, right? It sort of adds a multiplying effect to the dynamics. And so I think it is certainly an important discussion to have as we continue to learn and approach how we can alleviate some of those dynamics as we progress. So our panel today will provide us with some of their incredible experience to really illuminate the issues, and I hope provide some perspective on how we can improve the dynamics over time. In early 2020, CMS published a request for information seeking feedback on coordinating care from out-of-state providers for Medicaid children with medically complex conditions. They opened that, unfortunately, in the midst of the burgeoning pandemic. So I don't think they got much response to that initial RFI. So they extended that for additional comment period in through the summer of 2020. They collected about 90 some odd public comments from what I was able to see from the websites. And then just a couple of weeks ago, CMS provided some guidance. I have that in quotes, and an informational bulletin that includes some suggestions and best practices based on those RFI responses. Again, really to encourage state Medicaids to improve care for kids with medically complex conditions across state lines. That's referred to as the guidance on coordinating care provided by out-of-state providers for children with medically complex conditions. My impression of that, I will be eager to hear from our panelists, that it's a good place to start, but not a lot of teeth. And so I think much of the discussion today perhaps is how we can build on that start. With that, I will quickly, or not so quickly, introduce our panel members and then turn it over to them to provide their perspective and their thoughts on ways to improve the dynamics. So first we have Kelly Maynard, a woman that of course none of us here needs much introduction. She's the founder and president of Little Hercules Foundation, and I'm always amazed by her strength and tireless energy. And of course, the Little Hercules Foundation works to improve the lives of those diagnosed and the families facing Duchenne muscular dystrophy. Dr. Maura Rushnikov, hopefully I did a decent job of that, is a pediatric neurogeneticist at Stanford Neurogenomics and at Stanford Children's Hospital. And listening to her video profile as I prepared for this, I was struck by the term she used, rare disease navigator, that great specialists such as herself have to help put the really confusing constellation of rare symptoms together like a puzzle, and these specialists have to then help their patients and families make sense of it all. In addition to that medical component, which is no small feat, I am sure that providers also must then help their families navigate the complex and often siloed insurance system when it comes to rare diseases and exceptions. And so we look forward to her perspective. Following Dr. Rishnikov, we will have Christopher Fields, Director at Orchard Therapeutics. And we again thank Orchard for their sponsorship of this panel. Christopher will provide some perspective from his current position and his past job experiences in rare disease, and really underscore those complexities as a company like Orchard and how they partner with families and providers in trying to really address some of these dynamics. And last, but certainly not least, we will have Kip Piper. Kip is an expert on Medicaid and Medicare policy and a consummate strategist and a highly creative problem solver. I've worked with him for a number of years, and it is quite true. He advises life science innovation, state Medicaid agencies, major healthcare providers, and investors on complex access, coverage, and reimbursement challenges. He's a wealth of experience, and his experience includes a state Medicaid director in Wisconsin, a state public health officer, a senior advisor to the CMS administrator, and a senior budget staff at the OMB. So we look forward certainly to his perspective as we move forward and hopefully illuminating perhaps some paths forward so we can improve the dynamics. With that, I will turn it over to Kelly for a few words.
Thank you so much. Kitty, if you could please pull up that map. Thank you. So as Angela mentioned, my name is Kelly Maynard, and I have a 14-year-old with Duchenne muscular dystrophy, and he was diagnosed at 5 years old. Some of you probably know a lot about Duchenne. For those that don't, Duchenne becomes a very disabling disease in early adolescence, early teens, fast progressors. My son lost ambulation at the age of 9, and he's been in a power wheelchair ever since. And so I wanted to show you this map. This is where all of our, and this map is the Parent Project Muscular Dystrophy, our largest Duchenne advocacy organization. This is a map of where all of our certified Duchenne care centers are located across the country. So because Duchenne is very disabling at an early age, many of our patients qualify for Medicaid through the Home and Community-Based Services Waiver Program in their states. So a large percentage of our patient population has private health insurance as primary and Medicaid as secondary coverage. So if you take a look at this map, I live in Ohio. So if you're looking at Ohio, we have 3 certified care centers in Ohio. So it's pretty easy for us to get to really good quality care to get our children treated for Duchenne. But if you look, Montana, North Dakota, South Dakota, Arizona, New Mexico, there are large swaths of our country that many of our patients have to travel out of state. And actually, it's probably more common than not for families to travel twice a year for their biannual clinic appointments, which are very long days, six hours minimum, requires either plane fare, hotel cost, that sort of thing. So what we see a lot with our patients is there are centers, especially if you live in this whole area, Tennessee, Alabama, Georgia, Louisiana, a lot of those families will travel up here to Ohio for care, either Cincinnati or Columbus. And what that requires is if they are covered by Medicaid, they have to ensure that there is some kind of payment agreement already in place with that facility and their state Medicaid program that they actually can bill, and the state will reimburse. Where that is in place, that works pretty well. But that's not always the case. All of these centers do not have payment agreements for all 50 states, right? They may have them for some surrounding states. And the other problem that we see is, for example, if you live in Minnesota and you want to go to this clinic right here, which I'm not sure which one, I think it's Illinois or Michigan, maybe. Your state Medicaid program may approve you to go to one. Well, I guess that's a bad example because we don't have a center in Minnesota. But if you live in this state, it might be a lot faster for you to go to one of these clinics that's right across the border than travel 5 or 6 hours to one that's actually in your state. So we see that quite a bit, and families ask us, well, it's an hour drive for us to go to this one clinic that's right across the border as opposed to this 4-hour drive. And so those are just kind of the examples that we hear pretty often. There are some other issues that come up, not all the time, but they're, nonetheless very challenging and stressful for families to experience. And that can be, for example, we have one center in Massachusetts, and it is a very popular center, and a lot of our patients go, and they don't, and I hope I'm saying this correctly. If any of my staff are on the call, feel free to jump in and correct me, but they are, so the certified care centers have to provide certain levels of care, comprehensive care, in many, many different disciplines in order to become certified. The issues arise when, say, the clinic doesn't provide in-house imaging, MRIs, and they have to outsource that. And for some reason, that isn't considered either in network or is not approved as a Medicaid vendor. And so we've seen some issues there. And so predetermination becomes really, really important, so that families aren't left with huge surprise bills, even with primary and secondary coverage. So I think, and as always with rare diseases and complex, this is just a small picture, right? Traveling to your biannual clinic appointment and figuring out how to get there. That's really one small piece of the overall picture of providing care to a medically complex child. There has to be consideration that if you're traveling to these out-of-state clinics, but your providers are prescribing something, they have to prescribe it where you can access it, right, in your home state. So, it becomes really challenging when you're looking at the total coordination of care. And as someone mentioned earlier, I believe it was my friend Crystal, who said, that largely does fall on the families, and our providers do a wonderful job in helping us coordinate that. But to be honest, administratively, we know that they're overburdened now that we have 5 approved treatments for Duchenne, that's just happened in the past 5 years. So it becomes a complex issue when you're trying to, get the best possible care for your child with Duchenne. So, also, and I think it's important to mention that these are the centers that are going to be conducting the clinical trials, right? So access to care, also, we're talking about access to clinical trials. We're trying to get clinical trials filled and moving forward and making sure the science continues to move forward. So that's a consideration as well. We know that there's not a lot of travel and financial support for these families. And so we do offer a family assistance program where we will cover these travel costs because we do recognize that, getting the best care is important, but continue, if we can't get these clinical trials filled, that's a big problem. And so we want them to get to where they want to go. So, and that's, and the last thing I'll mention is there are things that are so far out of the patient's and family's control. We had an issue in Illinois where many of our patients that had been going to, that were covered under Illinois Medicaid were traveling to other clinics, that they had a payment agreement in place, but that facility or that provider just stopped accepting Illinois Medicaid payments because they just weren't getting paid for years. This was happening. And so just a few examples of how challenging this can be. I mean, I consider myself, grateful that I live here in Columbus, Ohio, and I can get within 2 hours, 20 minutes, I can go to one of the best care centers in the world to treat Duchenne. But I can also, go to 2 others and try to access clinical trials for my child. So I hope this gives you a picture of, somewhat of the daily life that we live. And I'll turn it over to whoever's next.
Thank you, Kelly, and I appreciate the visual, because right, I think sometimes we think, oh well, it's just getting an agreement with the neighboring state,
Right.
but it's not, right? It can be a number of states away, and so I think that's an important reminder. And right, the map can look very different for a different rare disease, so that makes an additional challenge. Well, with that, I will turn it over to Dr. Rishnikoff.
I do have a couple of quick slides, but I don't know if you have them or if you want me to share my screen.
Oh, okay.
I'm pulling them up right now.
Oh, great. Perfect. Well, great. So I know I had a little bit of an introduction earlier, but just to reintroduce myself a little bit, I am a pediatric neurologist and medical geneticist, and I focus only on the care of children with rare disease and specifically rare neurological diseases. So all of my time spent in the clinic is with children with rare and complex medical care needs. So this certainly is relevant to our clinical practice. And I don't, should I tell you to move forward? I don't know. I don't have any disclosures that are relevant to this talk. So I know most people on this call will of course know this, but just to briefly talk from kind of a physician's perspective, why do people need to go out of state for their care, especially with complex care needs or with rare or genetic conditions? And I think, our last panelist really highlighted this so well, is that not every state and even not every county or city, et cetera, is going to have a doctor or a care team that has not only expertise, but honestly, even any experience with an individual's condition. And so absolutely, that's probably the main reason why travel is so important in this population. Additionally, as certain medications New therapies are approved. Typically that is only rolled out at very specific and specialized centers. And that's also true for specific types of procedures. For example, if a treatment needs to be given in the spinal cord or even in the ventricles of the brain, those are specialized techniques that not every center is going to be capable of taking on when those therapies are approved. Additionally, I think this was kind of highlighted as well, is that this is also so state and region specific. Sometimes there's lots of access to specialty care, sometimes there's very little or none. And even sometimes, depending on where you live, the center that can care best for your child or dependent is actually, it's closer for you to be out of state than within the state. So there's lots of kind of regionality specifics to this. And then long wait times, I don't want to sound flippant. I don't think anybody's saying, well, I just want an appointment sooner. But the issue here is that sometimes treatment or expertise about a specific condition is timely and needs to happen quickly. And if there's no one nearby who can address those issues quickly, then you need to go somewhere else. And so, long wait times are relevant and important. And then one thing that I think is really important to remember is that I think that when we talk about crossing state lines for anything related to kind of run-of-the-mill medical care, so maybe not going to a multidisciplinary center, but having any of your other needs met. Often we talk about it in the context of emergencies, but I think it's important to remember that children with rare or complex care needs don't just stay home all day or stay within one state for whatever. They have the same, their families have the same hopes and desires as every other family. They want to travel, they want to visit family. There's no reason for us to kind of assume and then set up a medical care team and system that can only treat our complex care needs within one state or in one kind of care group. It's not realistic and it's not really fair to children with complex care needs. Next slide. So I have a very similar map to Kelly, so I thought this is a really good way for us to drive home this point. This is actually from a review article that our team had written about leukodystrophy care recently. And what you see on this map here is what are called certified leukodystrophy care network centers, or those that are working on becoming certified centers. And just as Kelly pointed out, if your child has a rare condition in which specialty care is needed and multidisciplinary care is needed, especially with people with experience or knowledge about those conditions, those centers are not going to be everywhere. It's just not possible, and those resources just don't exist. And so there are going to be areas where it's relatively straightforward to get care, or at least a neighboring state with a good kind of cross-state agreement is already in place. But other times there's going to be absolutely nowhere close to you. And so this is going to be true for every kind of rare disease and rare disease group or other complex care needs. It's always going to be kind of scattered throughout the state or the country. Next slide. So just to give two examples, I tried to really keep this being from the physician perspectives, because I know we have panelists from kind of all sides of this issue. And so I think probably the most ubiquitous issue that we come across is, again, the same kind of issue that Kelly was alluding to. Your child or your dependent is given a diagnosis, you do all the research, you find out the best place for them to get care. And then maybe you need a referral to that center, and your pediatrician is more than happy to place the referral, but then it's denied. Often the reason for denial might be something like, well, there's already a child neurologist in your state, for example, who is contracted. Well, that's a really big problem, because now the person who has to appeal that denial is not the person with expertise in this condition and may not have the resources to do that appeal. And so now we're asking our kind of local providers to take on the complexities of both the Medicaid system and appeals process, but also to make the argument for why they should be seen at this specialty center. And they're not really the right provider to make that argument. And so it's really set up this very challenging situation where the specialty centers can try to provide information or, have source letters that they can give people to try to make appeals, but it really puts so much of the legwork on both the families, the local providers who are already often very resource limited, and then even the specialty centers who need to help get this sort of approvals through. So this is probably the most common and ubiquitous thing we see as specialty centers for different disorders, is that there isn't really a person who owns this process, who is knowledgeable about these conditions and or the way to get things like prior auth and appeals through. It ends up landing on people who really will have a lot of trouble getting this done, and it leads to a lot of delays in care. And the one other thing that I want to mention is kind of a rare disease doc in general, is that what happens in these scenarios is that even if a local team tries to take care on, because the condition is unfamiliar to them, very standard things and symptomatic management sometimes won't happen, not because the doctors don't want to help, but because they're not sure if it's possible and they're scared of the unknown. And so it really makes, families have to be such strong advocates and basically experts in the conditions. And it really sets up a problem for adequate care for kids with complex care needs. The next slide. And this one, I wanted to be a little bit more forward thinking, because this is a newer issue that's coming about, which is we are starting to revolutionize how we diagnose conditions that may have a therapy as early as possible. And there are more and more conditions being diagnosed or screened for with the newborn screen in different state programs. And so nowadays you can have your child test positive for a very scary disorder in which not that many people have expertise. You can have that diagnosis confirmed and find out, wow, okay, I got this scary diagnosis, but at least there's a treatment. And then what can happen is that there can be no one who's really able to do that treatment within your state, or who's contracted with your state Medicaid program or the program that you're enrolled in. And so this is a huge issue with lots of examples these days related to disorders such as ALD, SMA, and in the very near future, I hope MLD as well. This really is an issue because this is an urgent thing. These treatments need to happen as soon as possible. And so any kind of hiccups with prior auth and approval of therapies and out-of-state medical treatments can really lead to devastating consequences. And we're kind of setting people up for these kind of failures by, rolling out programs within the states without making sure that there are also aspects in place that make sure that the treatments that are available for what is being screened will be covered easily, even across state lines, because these treatments are not going to be available everywhere. And there are not going to be people with expertise in these therapies everywhere. That's just a rule, and that will not change anytime soon. Next slide. So I think I kind of highlighted some of the challenges in just talking about, cross-state care in general. But a key problem that's a problem with insurance in general, but especially here, is that in general, the specialists are not the decision makers. So the person who is getting the prior auth or the predetermination request, or being asked to cover a service or a procedure or any of those things, whether it's in or out of state, to be honest, is not the person with expertise in the condition. And this is a very, very big problem and a very time-consuming problem, because now our caretakers or our specialists who want to spend time caring for children with complex care needs are needing to spend hours on peer-to-peer calls, or making denial arguments or appeal arguments for denials, et cetera, because we are just not being asked our opinions or what the standards of care are, and the people making the decision just don't know. I think we already kind of highlighted the fact that specialties and specialty centers are a limited resource. This is kind of by design and is very hard to change in the short term. And the types of therapies that are needed for these conditions are also often specialized, especially when we get into the realm of genetic therapies, and they will not be available everywhere. Another thing that's really important is that care coordination is really not valued in our healthcare system. And I know it sounds very negative, but even within states and within hospital systems, care coordination is very much lacking. And so to imagine how that could then stretch to adequate care coordination across state lines, it's very worrisome because we can't even do it locally. So how are we going to do it well across state lines? And then I think two other things that are important to mention are just that complex medical care or care for rare conditions takes time. We need to look things up. We need to speak to other experts. We need to really do our due diligence because, we're learning new things all the time, where we'll see conditions we just don't have as much experience in, but we have experience in a related disorder, et cetera, et cetera. And so in general, we're under-resourced and we don't have a lot of time to address the issues that come up with care coverage or coverage for different services and treatments. And then just to kind of bring home the points that I brought up earlier, that complex care doesn't end at the state line. Individuals who have complex care needs, whether it be specific tubing, a walker, all those things, the need for those things doesn't stop when you leave your state. And so that always needs to be put in consideration and is certainly a challenge. My last slide, areas for improvement. I think, to be honest, the list is never ending. There are so many ways that it feels like things could be better, smoother, faster, more equitable. But a couple of kind of specific things that maybe can be worked on in the shorter term. There is a need for providers who are kind of paneled as Medicaid providers for their services to be covered by an out-of-state contract. They need to be enrolled in that state's program. There are efforts to make that faster. I personally don't think it should be a problem at all. I think if you've been paneled in one state, that should be honored by all states. There's nothing different about how we are approved or our qualifications. It's just paperwork and time, and that's not appropriate. I think there should be more access to telehealth consultations, and they should be covered at the same rate as in-person consultations so that hospitals will want to provide this service. Because I think this really helps with the in-between care issues, or maybe even an initial evaluation out of state. We absolutely need more caseworkers and patient care navigators. It's just not right that all of this complicated system within states and even within states is falling on families and providers who want to be taking care of either their children or their patients. All of this time is taking time away from those very important needs. And it's happening, everywhere. We are just not focusing or investing enough in patient care navigators, caseworkers, and care coordination. And it is so, so important. And then the last thing is just another thought about how to help with this sort of thing. Is having kind of panels or groups of specialists who can help the states make decisions about coverage of new therapies rather than having to wait for multiple prior auth requests or for the issues to arise, or also for groups, within our own group here, we've taken the initiative to reach out to our state Medicaid programs when we know a therapy is coming about to talk about it being covered or what their policies will be, but that shouldn't be on us. This is a system that has been designed and rolled out in each state in different ways with lots of nuances. And if that's going to be the case, then we need a way to be able to convene experts and have the help to do so, to make these sort of decisions. And the decisions should be made by people who are knowledgeable about the condition. And that's it. That's all I got.
No, thank you. This is wonderful, and certainly provides certainly that documentation and that thinking of the dynamics, and I appreciate the areas for improvement as well, because I think that there are some things, like I said, the list is long and there's a lot to do, but there are places I think we can start. Christopher?
Yes, can you hear me?
You sound great.
Sounds good. I have a few slides to share. I, like Dr. Rushnikov and Kelly, a lot of the issues are very similar as far as the industry is concerned, as far as patient advocacy, as well as the providers. So you'll see and hear a lot of the same themes. All right. My name is Christopher Fields, U.S. Market Access for Orchard Therapeutics, and providing the industry perspective on cross-state Medicaid. Next slide. I'm not going to read this disclaimer, otherwise it'll take all my time. So I'm just going to share a few points. The fact that we do not have an FDA-approved product. This is not a promotion or advertisement for any of our potential therapies coming to market. About Orchard is my agenda, and then we're going to talk about, she's pretty quick here, Katie. And then the considerations and complexities of medically fragile children and challenges with Medicaid. Next slide. Next slide. I think everyone's wondering, what are the challenges? Well, first of all, I want to share briefly about Orchard. You know, I believe Jennifer Snow and Mike provided a great description of Orchard. We're a very small biotech company trying to develop gene therapy for devastating disease. As you will note, there are a lot of patients out there, and we're trying to make sure that we help these ultra-orphan disease. We currently have 150 clinical trial patients treated up to date, and 11 years follow-up as far as the earliest patients treated. So we're very excited about where we are as far as the potential patients being treated right now. Next slide. I've scaled back our HS gene therapy platform. You know, just want to make sure that everyone briefly understands the simplified version. Dr. Rushnikov can share with you that it's really more complex than this, but to be simply shared is, first we collect the cells, then genes are genetically re-engineered and cryopreserved, and then therapy is administered at the hospital as an inpatient therapy. That's the down and dirty version of it. If you need to have more, I'm more happy to provide that, or you can reach out to Dr. Rushnikov to share more details about the actual process and the details within step 1 through 5. Next slide. This is why I'm here on the panel to discuss the cross-state Medicaid issues. If you look at this example I provided here, we have 3 care centers, or we call them qualified treatment centers, one in New York, one in Texas, and one in California. The patient is in South Carolina. As you can imagine, Kelly pointed out the fact that going across state, there's a lot of issues. There's a lot of concerns. The fact that there's a limited number of qualified treatment centers, as Dr. Rusnikov pointed out, the fact that there's a few expertise in that particular skill set. There's a few expertise in that particular disease state. So that's the reason why there's a limit to the number of care centers. Also, it takes approximately 18 months for a care center to be identified and then go through the vetting process by the industry and then be approved. So it takes quite a long time to get that done. So the important is the fact that we want to make sure that everyone understands that we're not limiting the treatment care centers because we can. We're limiting the care centers because the reality of only a few expertise in that field. So that's the reason why there's a few care centers across for Duchenne's, and then also potentially for our particular products coming to market. Next slide. As you've heard in the past from Kelly, the inconsistencies from one state Medicaid to the next state Medicaid, Illinois being a great example. There's different paperwork for Illinois than it is for Ohio. Even though you've seen one Medicaid, you've seen one Medicaid. That's the example. The fact that there's lengthy approvals. If there's a denial in that process, you've added a couple weeks onto that approval. Travel challenges. Once again, inconsistency, lengthy approvals, and travel challenges all lead up to a potential patient not being treated. When you're looking at gene therapy, there's an optimum window of as far as being treated. And sometimes these lengthy approvals can take up to 4 to 5 months. And that patient can unfortunately not be able to be treated because of the lengthy approvals. And like I said, there's a treatment window, and we want to make sure that we eliminate those to the point where once the paperwork is started, we know it's going to take only a short time to get that patient through. Next slide. Qualified treatment centers or care centers or centers of excellence. The challenges, there are many, and I'm going to highlight just a few. The fact that prior authorizations, certification, it takes a qualified treatment center to be certified within that state. They also have to be certified in the next state where the patient is coming from. The example, patient coming from South Carolina that I showed that's going to Texas, well, that patient will have to be approved through state Medicaid for South Carolina, and then South Carolina has to work with Texas to get the paperwork and all the approval. So navigating the complexities of payer approval is very challenging, especially for a parent that's dealing with a devastation of learning that their child has a rare disease. So you compound that along with trying to do the paperwork, they become confused. And sometimes, unfortunately, I'm sure Kelly can share the fact that some of these patients will, and the caregivers will just drop out of the system and just try to manage the system and try to manage the care on their own with their local physician, where obviously the best care would be at one of those care centers or qualified treatment centers. So we have a system that is basically set up for chronic care. We're talking about a one-time optimum therapy, gene therapy, that we're hoping that we can correct that with some of the things that we put in place. Next slide. As you can see, even with in-state qualified treatment centers, the patients in-state, there's a lot of paperwork. But now you go to the out-of-state, just the visual effect, you can see the complexities. And actually, I've not even put in the fact that if the appeals process, so the appeals process tacks on additional paperwork. So this is if everything goes through and the process is done as prescribed. These are all the necessary steps for an out-of-state patient to qualify to be treated at California, Texas, or New York, or Cincinnati, Ohio, depending on where the care center is set up. So as you can see, a parent is being challenged with trying to get all the paperwork. Once again, there could be a physician that's being challenged with trying to get all this paperwork, and that's not their specialty. Their specialty is being a physician and treating the disease, not taking care of all the paperwork. Next slide. I have an example here as far as hospital-based services. And Dr. Rushnikoff can point out the fact that there's two situations. State Medicaid dollar is divided. One goes to the hospital and the other goes to the physician. The physician has to be identified and set up within that particular state. The example I've identified here is an Arkansas-based patient. The payer, state Medicaid, may deny reimbursement for the Wisconsin-based physician. So the Wisconsin-based physician has to be set up with Arkansas state Medicaid. So once again, the payer or the state Medicaid may approve the payment, but the physician is hung out to dry. And so that's the reason why I'll give you an example. In 2018, CAR T came to the market, and there was a lot of patients being approved, but the hospitals started to deny because the reimbursement was not adequate for the treatment. And so we want to make sure that reimbursement payment is, some type of compensation for both the hospital as well as the physician. So these are the cost containments that we experience as far as industry trying to deal with state Medicaid issues, as far as making sure that everyone is being compensated properly, both physician as well as the hospital. And that's the reason why it takes so long to vet a qualified treatment center or a care center or a center of excellence to make sure that everyone understands the complexities of reimbursement. Next slide. I think we've shared this, everyone has seen Kelly's slide about the travel considerations, planes, trains, automobiles, getting a patient cross state lines. It all has to be approved first up front. Lodging the same way, getting a person set up. Oftentimes the Ronald McDonald houses are full. And so you had to find alternative lodging, whether it's at a hotel or they do a GoFundMe account to get lodging. I know, for example, that my previous role with Novartis and Avexis, we had a patient go from Kentucky to Florida for treatment. That patient had to set up a GoFundMe account to get lodging for the parents. So those are different challenges that are, we're trying to obviously eliminate those and work with state Medicaid, but unfortunately, it's a slow process. Meals, cost of the burden, being away from home. All of this requires a prior authorization and approval from state Medicaid in order to get all three satisfied. Next slide. Potential paths forward. As you've heard in the past from Kelly and some of the others, that there have been a few positive things come out from CMS. Recently, the guidance as far as coordinated care provided by out-of-state providers for children with medical complex conditions, which are strides as far as improving that. We have to do more. We are working with a lot of the patient advocacy groups here at Orchard, and then also working with the providers to make sure that we lessen the burden for out-of-state Medicaid. We also are trying to accomplish something that hasn't been done before. As I pointed out, going across state lines, state Medicaid and even commercial payers, truly we're trying to change the paradigm as far as the understanding of one-time treatment therapies for these patients. And it's a slow process, but we're not going to give up. We've talked about the fact that smaller organizations, we don't have a lot of resources, but the one thing that we have is determination to make sure that we partner with these patient advocacy groups and do everything we can for these patients, because it's devastating to learn that your child has been, unfortunately, dealt with a orphan disease, and you have to go through this process. And we want to make sure that we partner with everyone, both the caregiver as well as the patient, as well as the patient advocacy groups, as well as the providers. So we're all in tandem. Next slide. This is my last slide, and just want to point out that there are certain things that we can do as far as working with the providers and the state Medicaid and commercials as far as trying to get drug carve-outs. A carve-out is a modification to either payment, separately handle high price ticket items such as gene therapies. We can either do a drug carve-out or disease state carve-out. Those are options. Kick payments, that's another option where allow certain services be provided. For example, when a mother, expecting mother, they provide additional services for maternity care. And so those are kick payments where additional services will be provided for that particular Medicaid patient. So I just want to make you aware that we at Orchard, and there's others in the industry, we're working very hard to try to, work at trying to provide a solution for these patients and medically challenged kids that unfortunately have been dealt with an orphan disease. So with that, I'll stop and turn it back over to the moderator.
Thank you, Christopher. And I will quickly hand it over to Kip. I'm anxious to hear from your perspective where your thoughts are on how do we start to tackle some of these issues and where do we start?
Oh boy.
In 10 minutes or less.
Yeah, exactly. Well, luckily we figured it all out. No, I'm just kidding. The frustrations, and these are just overwhelming issues, but fortunately everybody's quite motivated to be able to find ways of solving them. I'm going to give just a few little pieces of advice. Other folks have touched on many of the same areas. Christopher just mentioned about payment, for example. It's absolutely critical, of course, and particularly for patient advocacy organizations and others that are involved here, to understand the flow of the money. And I don't mean to be crass, but it's very important that the providers involved are adequately paid for their services. These are very expensive, groundbreaking, life-saving therapies, and we need to make sure that there's access. And a critical aspect of that, of course, is the payment mechanism. So one is to understand the different methods of it and also the adequacy of it. One of the reasons why, since somebody already picked on Illinois, I'm going to jump on and pick on Illinois here. Just a real quick thing is, they've never had a Medicaid fiscal agent system, an MMIS, as we say in the biz, and that allows them to bypass certain federal requirements that otherwise would require much more timely payment of providers. And Illinois specifically has always avoided having one of those federally certified systems, because if you had one and you took the federal money for that system for claims payment and so forth, they'd have to pay faster. And so there's these weird idiosyncratic factors in Medicaid. It boils down in many cases of blocking and tackling. We heard from it was Kelly, the first in the efforts by the providers and certainly the families of trying to just figure out the paperwork, the process, and so forth. One of the things is and what we need to do collectively is cataloging these different processes that states use, the mechanisms, because remember, this isn't intentional. These delays and snags and so forth are not intentional by these states. It's just that when we talk about rare conditions, they don't have that. They're not seeing that so many of those cases, and they're seeing different ones at different times. So they don't have, frankly, enough volume to be able to set up processes and devote limited resources to figure out, all right, how do we do this one? How do we set up a network of out-of-state providers? Who are they? How do we deal with those other states and so on? So what has to be done is others, whether it's the innovators and the patient advocacy groups and so forth, and frankly, working together across different disease states, right? To look at it and say, look, let's do the paperwork format, right? And the basic processes for them. Let's figure out that connective tissue. Let's write it up, create the best practices, and be able to share those. And then, frankly, exert pressure if need be in a nice, friendly way on those states to adopt those best practices and have as many states adopt those, whether that's the prior authorization standards and the steps that have to be considered. A lot of states, frankly, and I consulted on a lot of these, where the state ends up putting in speed bumps, if you will, that expect somebody to go through an extra step or an extra process or a step therapy and so on. That's may not even be relevant. It may even be risky. And it was the way that it was done 10 years ago. So, okay, well, you've got to, try and reject this particular approach. Frankly, that's inappropriate and often dangerous, and completely irrelevant for the purpose of today's therapies, which just sort of leapfrog over those. We've got to look at this and have standard templates for that assistance of how to make that request for the travel, the lodging, and the meals, and how it gets paid for, as easy and as simple as possible, both for the family member, the patient, and any other attendant person, nurse, other person that needs to be there. We need to start tracking and understanding and collecting the data on the denials, frankly, the process in appeals, how many of these have to get appealed, the time that Christopher was just mentioning about the time that it takes, okay? I hear these things, look, I understand it from the state perspective and so forth. It's a mess. Medicaid is the most complicated program ever created by humankind, okay? And it's very, very difficult. But with something that is so vitally important to and we're talking children here, for God's sake. Right. So this is why kids, but it's solvable. It's all solvable. And we've got to be able to put it together and show it so that the states can see it. All right, this is the time that it takes for this particular condition or these conditions. It takes 4 months on something which really days matter, not months, right? And the suffering and the potential life-threatening effects of those kinds of delays. We've got to look at what's the actually results of those appeals, so that, because you don't have to constantly be in a mode where everybody has to reinvent the wheel on appeals, because once somebody wins, you need to make sure that that win then is communicated around and everybody can then use that, and it gets, whether that's reinforced by the state onto, one plan lost an appeal, well then make sure that all the other plans and everything, it now becomes the standard policy. So there's processes like that that then can be institutionalized in a positive way, because they're efficient, they're more effective, they're clinically supportable, right? It's doing the right thing by the patient. States and their contractors and their plans don't want more paperwork any more than anybody else does. And so they want to be able to find that. So if we can standardize some of those and identify what the patterns are that create these delays, maybe it's a coding issue. Maybe it's a testing issue. Maybe it's just simply knowledge of like, oh, we thought that you needed a test for this before the, no, the person's already been diagnosed. This is what this is, what, those kinds of things. It's the block and tackling of that from the ground up, identifying the pattern and then providing exactly what the policies, the procedures that can be done. There are ways for states to pay out of state providers. There's, CMS mentioned some of those, certain kinds of things that can be done. There's ways to streamline the certification of those providers. When a provider decides, look, I'm not getting paid enough, and they're not satisfied, they're not getting paid fast enough, they're losing money, okay? And they're losing so much money they can possibly, eat it and absorb it. We need to know what those are and to be able to resolve those in as expeditious way as possible. So those are kind of some of the practical, it sounds very painful, but it actually isn't. Once you do some of them, you've now pretty much eliminated. And I've seen this happen with all sorts. I've seen this with complex transplants and drug therapies and so forth over the years, that once, and all sorts of different special populations, that once that's done, then it's resolved. And states do tend to follow each other. They don't want to reinvent the wheel. They want to follow, they want to do the right thing. And, but they don't have the time or the resources to create all these separate processes. So we could do a lot to standardize that for them and kind of make it a lot easier for everybody. So.
Yeah, I really appreciate that, Kip, and I imagine we could talk for hours on this topic. And
I just gave you the quick dump on that. But,
absolutely, yeah. And certainly appreciate that. I think what I'm struck by from the discussion is, one, probably justifies a task force approach because it certainly was striking, right? The couple of maps that we saw, or the 3 maps that we saw, right, hit different states. So this state thinking that, oh, we just need to make arrangements for a couple neighboring states doesn't work, right? That model doesn't work anymore. And Kip, to your point, maybe it is, let's figure out a rare disease solution for how they can improve access across really the nation, because that in some cases may be what's necessary. So I really appreciate everyone's participation.